Hello and welcome to Med Tutorials. This is your place for simple and easy to follow tutorials in internal medicine. Today is going to be level 6 in the series titled Decoding the ECG. In the last level, we saw an approach to ECG, a 12-step approach to an ECG. And today we're going to be dealing with the challenging problem of tachycardia in an ECG. Very often in emergency medicine, in critical care, one of the life-threatening situations is tachyarrhythmias. And you're presented with ECGs which show tachycardia, and you have to make a diagnosis and start a treatment. And this can be challenging at times. Is it a supraventricular tachycardia? Is it a ventricular tachycardia? Is it atrial fibrillation? Is it atrial flutter? Today we'll be approaching this topic of tachycardia in a systematic manner. And hopefully at the end of this tutorial, you'll be confident in identifying some of the common tachyarrhythmias. So let's get started. So we'll look at an outline of what we're going to do today. We're going to start with a brief description of the common causes of tachycardia. So before we actually approach how we're going to handle tachycardia, we need to know something about the different common causes of tachycardia. We're going to look into some confusing terminologies, and then we'll finally go into the stepwise approach of tachycardia on an ECG. And we're going to end by looking at some trial ECGs. So coming back to the basics, we know that the impulses normally start with the SA node, which is the pacemaker, and from there impulses go through the atria. They reach the AV node and the bundle of His, which is the AV junction. From there, through the bundle branches, the Purkinje fibers, the impulses spread to the ventricles. So these are the four main areas which are responsible for tachycardia. If you look at the SA node, sinus tachycardia is the cause which arises from the SA node. From the atria, we have atrial flutter, atrial fibrillation, atrial tachycardia. We have few terms like AVRT, AVNRT, which are re-entry tachycardias, and we have junctional tachycardia taking place at the AV node. Now, atrial tachycardia, AVRT and AVNRT are grouped under paroxysmal supraventricular tachycardia. And all these tachycardias which arise above the ventricles, above the level of the ventricle, they're termed as supraventricular tachycardia. From the ventricles, we can get ventricular tachycardia and ventricular fibrillation. So we're going to look a little more closely at these causes of tachycardia. Now, sinus tachycardia. We know that the SA node, sinus node, is the normal pacemaker of the heart. What happens in sinus tachycardia is that the impulses are generated from the SA node but at a rate that is faster than normal. So if you look at an ECG in sinus tachycardia, it's going to be normal except for the faster rate. Now coming to atrial tachycardia, what happens in atrial tachycardia? Here we have a focus in the atria other than the SA node which generates impulses. And these impulses are usually generated at a very fast rate, and if there is only one point of focus, it's known as monofocal atrial tachycardia. Now here if you see this ECG, the first complex marked in blue is a normal sinus P wave, and the red ones are the P waves which originate from the focus, ectopic focus in the atria. Now sometimes what happens is you can have multiple focus in the atria which sends impulses. This is known as multifocal atrial tachycardia. Now if you look at this ECG, if you see the P waves, they're all different in morphology. That's because the atrial impulse focus is originating at different areas in the atria. Now we're going to look at a term known as AVNRT, that is atrioventricular nodal reentrant tachycardia. Now here what happens is that you have a re-entry tachycardia taking place at the AV node. There's a re-entry of the stimulus in the AV node. Now usually this is with people who have a dual channel in the AV node. One of the channels is a fast channel and the second channel is a slow channel. So here's a diagrammatic representation of this dual channel in the AV node. What happens is the impulses go down the fast channel and they turn back and into the slow channel, and then there is a spinning which takes place in the AV node, which results in impulses being sent out in a very fast rate. And this is what we call atrioventricular nodal reentrant tachycardia. Now, because the stimulation is taking place at the AV node, we see that these stimulating impulses go backward into the atria and forward into the ventricles. So we have an occasion where the atria and ventricle are actually being stimulated at a similar time. So very often what happens is atrial depolarization is masked by the bigger ventricular depolarization. That's why the P wave might actually be hidden in the QRS and you won't see a P wave on the ECG. But sometimes the atrial depolarization may be a little delayed compared to ventricular depolarization, and there you might get a retrograde P wave. Coming to atrioventricular reentrant tachycardia. Now this is known as AVRT. You notice it from the previous one, that was AVNRT. So there's an N missing from here because here the re-entry is actually taking place at a bypass tract between the atrium and the ventricle. So there you see a bypass tract. So what happens is there's actually a re-entry. It goes in normally through the AV node, but a re-entry is taking place at this bypass tract. And there you have a re-entrant tract which causes impulses being generated at a faster rate, and here again it's going retrograde back into the atria and also forward into the ventricles. So if you see the ECG, you might actually get a similar picture to the previous AVNRT as well, although the retrograde P waves might be seen a little more away from the QRS complex. But in practice, it can be hard to differentiate AVNRT, AVRT, and atrial tachycardia. That's because most commonly these three entities show up as regular narrow complex tachycardia with either absent or retrograde P waves. So it can be extremely difficult to differentiate these three in practice by just looking at a 12-lead ECG. That's why these three terms are broadly diagnosed or grouped under paroxysmal supraventricular tachycardia. Now I just want to look into the issue of confusing terms, because you're going to hear these terms again and again, SVT, PSVT, and it could be confusing. Now SVT, supraventricular tachycardia, is a term to include all forms of tachycardia that originate above the level of ventricles. So anything above the ventricle, any tachycardia originating above the level of the ventricle is termed supraventricular tachycardia. Paroxysmal supraventricular tachycardia, the second term that we're dealing with, is a subset of the above. So when you have paroxysmal attached to supraventricular tachycardia, we're actually talking about a smaller subset of supraventricular tachycardia. Now by paroxysmal we mean episodes or attacks of a form of tachycardia. Now here again we need to understand that these episodes or attacks can last from 30 seconds up to few days. So when you observe an ECG, you might not always observe it as ECGs which show a normal sinus rhythm and then attacks of PSVT. We do not see that, but we see the whole ECG as the episode of PSVT. That means you're not going to see normal P waves and episodes, but you're going to see the whole ECG is actually a PSVT. So these terms can be confusing, but over a period of time you will come to understand them. Now there is another tachycardia which originates at the AV junction, and it's different from AV NRT. Now what happens in junctional rhythms? There's a term called junctional rhythm where the AV node takes over as the pacemaker of the heart, away from the SA node. And from the AV node it sends out impulses in a retrograde and in a forward manner. This is different from AV NRT, where in AV NRT you have impulses which keep re-entering through a dual channel in the AV node and causes a spinning sort of stimulus which takes place. Now if you look at junctional rhythm, there are three types of junctional rhythm based on the rate. Now the normal junctional rhythm, the heart rate is 40 to 60. So normal AV junction, if it was to act as a pacemaker, the impulses are usually sent out at a rate of 40 to 60. But if the junctional rhythm gets faster, that is accelerated junctional rhythm, the heart rate goes from 60 right up to 100. And if the heart rate is more than 100, that's when we term it as junctional tachycardia. So in junctional tachycardia, the AV node is behaving as the pacemaker of the heart, and it is sending out impulses faster than it usually does, and that heart rate is 100. But what we need to understand is usually it is less than 130. The AV node cannot generate impulses on its own at a rate that is above 130. So even in junctional tachycardia, the heart rate will be between 100 and 130. So here if you see the ECG, as the impulses are generated in the AV node, the impulses go backward into the atria and forward into the ventricles. So because they're going backward into the atria, the P waves, if visible, you're again going to get retrograde P waves, that is actually inverted P waves. Now these P waves can be either appearing before, or they might be embedded in the QRS complex, or they might come after the QRS complex. So you have these retrograde P waves. So very often what happens is they might be embedded in the QRS and you might not get any P waves at all. That's because atrial and ventricular depolarization takes place at the same time. So that is why we don't see P waves, because they are sometimes buried in the QRS complex. Now, as I said earlier, the rate is a major clue. Junctional tachycardia never goes above 130, and that's a major clue in narrow complex tachycardia. To differentiate it from the other tachycardia, other PSVTs, this is a major clue. Now we're going to look at a term called atrial flutter. What happens in atrial flutter? Now here we have a single stable re-entrant pathway taking place at any place in the atria. So it's again like a re-entrant mechanisms. As I stated earlier, these re-entrant mechanisms cause the generation of impulses that can take place at a very fast rate. And so what happens is, because of these re-entrant pathway, you have the atria which depolarizes at a rate of 250 to 350, and these impulses are then conducted through the AV node and to the ventricles. Now the atria depolarizes at a very fast rate, but the ventricle responds in a fixed manner. What that means is that not all these beats from the atria are conducted into the ventricles. That's what we call a response in a fixed manner. So you can have terms such as 2:1 or 4:1, meaning that for every 2 impulses from the atria, only 1 is conducted into the ventricle, or 4:1 for every 4 impulses in the atria, only 1 is conducted. Sometimes you can have variable conduction and not a fixed conduction. Now take a look at this ECG of atrial flutter. If you see, you can see that there are 4 P waves, and it's only the 4th one which gets conducted into the ventricle. And this is what we call a 4:1 conduction. Atrial flutter with 4:1 conduction. Now the ECG in atrial flutter is a very characteristic look. If you look at it's called a sawtooth appearance. Basically, it's because of the P waves, or the atrial depolarization waves, which appear quite fast, and that gives it the sawtooth appearance. Next, we're going to look at a term called atrial fibrillation. Now, this is a relatively common form of tachycardia that we see. And here what happens is that you have multiple unstable reentrant circuits. In the previous one, in atrial flutter, we had a single stable reentrant circuit. Here you have multiple unstable reentrant circuits in the atria. And these sort of fibrillate or causes depolarization that are not well sustained or regular. And these impulses are then conducted through the AV junction and into the ventricles. So it's a very irregular fibrillatory contraction of the atria, and when they're passed into the ventricles also, it's not in a very regular manner. So what we see is an irregular response of the ventricles. Now this is a classical ECG in atrial fibrillation. And if you see the P waves, because there is no proper contraction of the atria, we have absent P waves. But what is sometimes seen is an undulating baseline, which actually represents the fibrillating atria. And if you look at the QRS complex, we see irregular QRS complex, varying intensities, varying amplitudes, varying rates of the QRS complex because of the irregular transmission of impulses into the AV node and the bundle branches and into the ventricles. Next, we're going to look into ventricular tachycardia. So now what we had dealt with so far were all supraventricular tachycardia. Now we're finally coming into the ventricles. Now in ventricular tachycardia, you can have a focus in the ventricular muscles. Maybe it's a scarred muscle from a previous MI, which starts generating impulses. You can have a re-entry circuit in this damaged myocardium in the ventricle, and they start generating impulses which go out at a fast rate. So the ventricles is the focus of impulse generations. Till now, whatever we saw was above the level of ventricles. Here, the ventricles become the focus of impulse generation. Now, premature ventricular complexes is what we call as ventricular ectopics. But if you have 3 consecutive PVCs, that constitutes ventricular tachycardia. So all you need is 3 premature ventricular complexes taking place together, and that would be labeled as ventricular tachycardia. As I said, it usually occurs on a scarred area like post-myocardial infarction. So the impulses do not follow the normal pathway of AV junction and the bundle branches. So that is why the QRS complex are broad. So as you saw from the diagram, these impulses are generated and they are not transmitted through the AV junction and the bundle branches. To get a narrow complex QRS, you need transmission through AV junction and the bundle branches. It's only when you follow that route that the ventricles contract or depolarize in a systematic manner to form a narrow QRS complex. But say if it's originating from a point other than this system, the impulses are transmitted in a different manner, not through the proper bundle branches, and therefore the QRS is broad. Now, classification of ventricular tachycardia. You have ill-sustained ventricular tachycardia, that means which is lasting for less than 30 seconds, versus sustained ventricular tachycardia, which is more than 30 seconds. Monomorphic is where you have only a single morphology of ventricular tachycardia because it's originating from a single point, whereas polymorphic is where you have multiple areas in the ventricle which have become focus of impulse generation. Now here is an ECG tracing of ventricular tachycardia, and what really stands out is the broad QRS complex. Now ventricular tachycardias are definitely much more life-threatening than the supraventricular tachycardias, and that's why it's so important and vital for medical personnel at every level to be able to identify ventricular tachycardias. So now we're coming to the 12 steps that we saw in the previous ECG tutorial on how to approach ECG. And when it comes to tachycardia, what are the steps that we are going to pay special focus to in analyzing ECGs with tachycardia? There are certain steps that you're going to pay more attention to. Rhythm, the rate, the P wave if it's present or absent, the PR interval if it is seen, the QRS complex, and of course if you have a normal ECG of someone who later has tachycardia, you're going to observe the QTC interval. This is especially important with ventricular tachycardias. But of all these steps in approaching a person with tachycardia, the QRS complex is going to be a most important, because this is most often going to help you differentiate supraventricular tachycardias from ventricular tachycardias. So let's go to the important steps. Now in rhythm, we're going to see in rhythm, is it a regular rhythm or is it an irregular rhythm? Now regular tachycardias, of course sinus tachycardia is usually going to be a most regular tachycardia, and your supraventricular tachycardias, many of them can be regular. Atrial flutter with fixed conduction, say 2:1 or 4:1 conduction, are going to appear regular. Junctional tachycardias also will appear regular. Ventricular tachycardia usually appears regular. What about irregular tachycardias, irregular heart rates? Now the classical one is atrial fibrillation, where you have an irregular appearance on the ECG. If you have a sinus tachycardia and you're having on the ECG frequent premature atrial contractions, the ECG can have the appearance of an irregular tachycardia. Similarly, multifocal atrial tachycardia, because you have different points in the atria which are generating impulses, the ECG can be irregular. Atrial flutter or atrial tachycardia, which has a varying conduction, that means you don't have a fixed conduction into the ventricle, can appear irregular. Of course, ventricular fibrillation is a very irregular pattern as well. So what about the rate? After you finish rhythm, you're going to look at the heart rate. Can heart rate give us any clues in ECG analysis? Two things which really stand out. Sinus tachycardia usually is not more than 180. So if you have a heart rate more than 180 with P waves and QRS visible, and the heart rate is more than 180, you might be dealing with atrial tachycardia rather than sinus tachycardia. This is more true in elderly individuals, where a heart rate of more than 150 in a resting state might actually be atrial tachycardia. The other thing is junctional tachycardia. As I mentioned earlier, junctional tachycardia, usually the rate is between 100 to 130. So if you have a rate more than 130, a narrow complex tachycardia, narrow QRS complex tachycardia with absent P waves or retrograde P waves, we usually consider junctional tachycardia as one of the differentials. But if heart rate is more than 130, we would go more in favor of an SVT or a atrial tachycardia. Then we look at the P waves. P waves, are the P waves normal? If the P waves are normal, then it's definitely goes in favor of sinus tachycardia. Now we need to know that sometimes when we deal with atrial tachycardia, all the P waves that we see in that ECG of atrial tachycardia, they all appear the same. So unless we have an ECG which was taken way earlier at a different time when the patient was in sinus rhythm, we might not be able to differentiate the different morphologies of the P wave. So different morphology from the sinus P wave is seen in atrial tachycardia, but that can be difficult if the patient is presenting to you for the first time in atrial tachycardia, because you have no idea what his P waves normally look like. If he comes to you with an old ECG taken at a time when he had sinus rhythm, and you see that the P waves are different in morphology when he had a normal heart rate and now when there's tachycardia, that is evidence that he's having atrial tachycardia. What if you see a varying morphology of P waves? This is seen in multifocal atrial tachycardias where the P waves will be of different morphology. Again, when you have sinus tachycardia with frequent premature atrial complexes, you will be visibly seeing that those PACs have a different morphology. We had seen so far the thing about retrograde P waves, and we usually look for retrograde P waves in 2, 3 and AVF. And atrial tachycardia, AVRT, AVNRT, junctional rhythms, all of this can have retrograde P waves where the atrial depolarization is actually taking place from lower down close to the AV junction. So all three of these can present with retrograde P waves. Sawtooth appearance, as I mentioned earlier, is classical of atrial flutter, and absent P waves, you can get that in PSVT, atrial fibrillation and junctional rhythm. So these are some of the things that you're going to look at in the P wave. PR interval, a short PR interval may be seen in WPW syndrome. This can be appreciated only when the heart rate is lower and patient is not having an SVT. In junctional rhythm and in atrial tachycardia, which is originating from a place in the atria which is closer to the AV junction, you might actually get short PR interval. But the key to approach, as I mentioned earlier and I'm mentioning again, is the QRS complex. A narrow complex tachycardia versus wide complex tachycardia. Narrow wide complex tachycardia should alert you to ventricular tachycardia, whereas if it's a narrow complex tachycardia, you're almost assured that this tachycardia is originating from above the level of the ventricles. So based on the QRS complex width, you have narrow complex tachycardia, and here we have a bulk of the different types of causes of tachycardia, like sinus tachycardia, all your PSVTs, your atrial tachycardia, your atrial flutter, atrial fibrillation. Whereas in wide complex tachycardia, you're dealing mainly with ventricular tachycardia. But there is a second tachycardia which is actually could be quite confusing, which is actually supraventricular tachycardia with aberrancy. Supraventricular tachycardia with aberrancy, and I'll be coming to that in the coming slide. So what is SVT with aberrancy? Is actually you have a tachycardia which originates above the level of ventricle, but because of some abnormality in its conduction in the ventricles, the QRS becomes broad. So these are the two things that we keep in mind when we deal with wide complex tachycardia. So SVT with aberrant conduction, just to try to make it a little more clearer. So what happens here is the tachycardia is supraventricular in origin. So if you see the ECG, it's got broad complexes, but in actuality the origin of the tachycardia is supraventricular and not in the ventricles. But then how does it get broad? So in the first instance, it passes through the AV junction. The tachycardia, whatever the origin, passes through the AV junction, but there might be a bundle branch block or related conduction delays which causes the QRS to become broad. In the second instance, you might have the bypass tract through which the impulses conduct, but this is a rare abnormality to happen, because usually even if there is a bypass tract, it usually goes through the AV node and re-enters through the bypass tract. To go directly through the bypass tract is a little more rarer, but these are the two ways in which an SVT can have a form of abnormal conduction into the ventricles and cause broad QRS complex. So this is a ECG sample showing an SVT. You see how confusing it can be for us, because when you look at it, suddenly you see a broad QRS complex tachycardia and you think of ventricular tachycardia, when actually it is an supraventricular tachycardia which has become broad because of an abnormal ventricular conduction. So how do we face this challenging issue, ventricular tachycardia versus an SVT with aberrancy? It's probably one of the most challenging issues in dealing with tachycardia. I'm just going to mention a few points, and you need to know that this is not absolutely essential for you. It's probably not meant for beginners, so even if you don't remember this, it's fine. But this is just to show you that there are few points that helps experts differentiate VT from an SVT with aberrancy. Features of AV dissociation favors a ventricular tachycardia. So by AV dissociation, you mean that your atria are depolarizing at a certain rate and your ventricles are depolarizing at a certain rate independent of each other. They dissociate from each other. So of course in ventricular tachycardia, the ventricles will be depolarizing at a much faster rate because it's an abnormal re-entrant circuit at a point. So ventricles depolarize at a much faster rate, and the P waves are appearing slower. So what happens is sometimes these P waves might be visible on the ECG, on some of the QRS complex, because it's at a slower rate. It's seen once in a while. Sometimes you get capture and fusion beats. Capture is where a sinus impulse from the sinus node gets transmitted through the AV node and actually forms a normal QRS complex in between all those broad complex QRS that we see. Fusion is a fusion of a normal P wave impulse that goes through the AV node and an ectopic through the abnormal ventricular wave, which fuse together and form a different type of complex on the ECG. How about the morphology of QRS? If you get an RBBB pattern in V1, it's more suggestive of an SVT with aberrancy. If it's a single broad R or a QR or a big Q, a big R wave, it might be a feature suggestive of VT. Then we look at the QRS width in VT. In an RBBB type morphology, if it is more than 0.14 seconds, or in LBBB type of morphology, if it's more than 0.16 seconds, these are more suggestive of VT. Meaning to say that the width of the QRS is a little more narrower in SVT than compared to VT. Another important differentiation might be QRS concordance. That means the QRS waveforms show near identical polarity in all the chest leads in VT. Now, if you have an old ECG which shows the presence of bundle branch block, and now the patient has come with tachycardia and is showing tachycardia with broad complex, then it's probably this patient has an SVT with aberrancy, because he has an old ECG which is showing a bundle branch block. So RBBB in V1 might be a feature of SVT, and this is an example to show QRS concordance. We see that all of them have near identical a negative polarity of all the waves, and this goes in favor of VT. Now, as I said, this can be extremely challenging to differentiate even for a seasoned cardiologist. The ECG that he's provided with may not show all the features I mentioned in the previous slide. So in such a scenario where it's almost impossible to differentiate VT from SVT in an ECG, we need to remember a few important points. When in doubt, always treat as a VT rather than an SVT. So you have an ECG and you're not clear, is this VT or a SVT with aberrancy? Treat it as a VT. Why? Because 80 to 90% of the wide complex tachycardias are ventricular tachycardias. So always remember, up to 80 to 90% of wide complex tachycardias are ventricular tachycardias rather than SVT with aberrancy. So SVT with aberrancy is an exception rather than the rule. VT treatment works for SVT but not the other way around. So this is another important point. You treat an SVT as VT, you will get a beneficial effect, but the other way around might actually worsen the condition. That's why we need to avoid intravenous verapamil or diltiazem, which we use in SVT, because this can actually lead to cardiovascular collapse when you're dealing with ventricular tachycardia. So I'm just summarizing these tables. As I told earlier, these are the important points. When you approach tachycardia, what are the steps in ECG approach that are important? Rhythm, rate, P wave, the PR interval, and the QRS complex. These are the important steps. In rhythm, we see is it regular and irregular. The standout irregular one is definitely atrial fibrillation, where it's irregularly irregular, and of course ventricular fibrillation is also irregular. There are times with sinus tachycardia, if there are if you have your PV premature atrial complexes where you might have irregularity, or atrial flutter with a varying block, you might have irregularity. But commonly what we see is atrial fibrillation with irregular heart rate. The rate wise, what are the important things we have to keep in mind? Sinus tachycardia, it's unusual for sinus tachycardia to go more than 180, and the other thing is junctional tachycardia. Junctional tachycardia never goes above 130. So if you're dealing with narrow complex tachycardia with rates more than 130, it's more likely to be something else, or like an PSVT which you're dealing with. Then we look at the P waves. The P waves, if it is normal P waves, you're dealing with sinus tachycardia, and if you have a characteristic sawtooth appearance, it's probably atrial flutter. In atrial fibrillation, there's no P waves, but sometimes you see that the baseline is fluctuating, and that's an undulating baseline, and that's because of the fibrillatory waves. And but many of the arrhythmias like PSVT and ventricular tachycardias, you might not get any P waves at all. The PR interval, again, if there's no P wave, there's no PR interval. And in sinus tachycardia, very important that the PR interval will be normal. Junctional tachycardia, you might have retrograde P waves with a short PR interval. QRS complex, again, as I've told repeatedly, this is the most important step in ECG approach, because it helps us differentiate ventricular arrhythmias from supraventricular arrhythmias. Ventricular tachycardia, ventricular fibrillation, much more dangerous in clinical practice, and they need to be picked up. And the clue is the QRS complex, which, if wide, alerts us immediately to the tachycardia being a ventricular tachycardia. So we're going to look into a few examples now. What I'd like you to do is probably pause the video and try out these examples, and then we'll see the answer together. So here we see that the rhythm is regular, the rate is around 125 beats per minute, the P wave is a normal morphology. Of course, we are assuming that even the patient when his heart rate was normal had a P wave of normal morphology. PR interval is normal, and the QRS complex is of normal width, it's narrow, and so the impression is sinus tachycardia. So here a differential diagnosis would be atrial tachycardia, especially if you have only one ECG of this person. We don't know if this P wave is how his P wave normally looks, or did it have a different morphology, and this is the morphology of an ectopic atrial impulse formation which causes atrial tachycardia. But on the whole, with a heart rate of 125, we would label this as sinus tachycardia. Now if you had the same ECG but the rate was more than 180, say that you saw the same ECG but rate was 200, that would go more in favor of atrial tachycardia, because sinus tachycardia usually does not go above 180. Now try this example, pause and try it. Here you see the rhythm is regular, the rate is around 150 beats per minute. The P wave is absent, you don't see any P waves, so no PR interval. QRS complex, narrow width, it's a narrow complex, narrow QRS complex. So the impression is a PSVT. A more definitive term rather than an SVT would be PSVT. That's why I told you it could be confusing terms, but it's better to label this as PSVT, paroxysmal supraventricular tachycardia. Here the heart rate is 150 beats per minute, so that gives us a clue as to why it's not a junctional tachycardia, but because I said the rate more than 130 goes more in favor of PSVT rather than a junctional tachycardia. So example 3, why don't you pause and try this out. So the rhythm is regular, the rate is 225 beats per minute, the absent P wave, so no PR interval. Now important thing that we notice is the QRS complex, it's wide, it's increased width. So broad QRS complex tachycardia should immediately alert you to ventricular tachycardia. SVT with aberrancy is the differential diagnosis, but if you apply some of the points, we see the QRS concordance, they all look negative. There's no specific RBBB type pattern, but as I said earlier, it's quite difficult to differentiate all the time ventricular tachycardia from SVT. So when in doubt, always treat such an ECG as a ventricular tachycardia. Now pause and try this ECG. So the rhythm is irregularly irregular. The rate is around 180 beats per minute. P wave is not well seen, or you just have an undulating baseline. There's no PR interval. The QRS complex is a narrow, normal width QRS complex, but what we see is varying amplitudes of the QRS complex. And that's classically seen in atrial fibrillation. I hope you'll be a little more confident now in approaching tachyarrhythmias in an ECG. Again, the key is to keep practicing what you have learned in the ECGs that you see. In the next level, we'll be dealing with the challenges of reading ECGs with bradycardia. So if you are interested in seeing more ECGs, please do subscribe, hit the notification bell, and hit the like button. So till the next time, bye-bye.